Good morning. Welcome to Grand Rounds. We're going to go ahead and get started this morning. I double-checked to make sure my cat filter was not on before I joined, so hopefully you can all see me out there appropriately. All of you who have joined us, your cameras have been turned off and you have been muted. However, we do invite your participation using the chat feature. You can do that by clicking on the right lower hand corner of your screen. We do ask that you put your questions to all panelists so that when we get to the end of the presentation, I can see those questions and give them to our presenters. As always, we do appreciate your feedback at the end of the Grand Rounds. If you could take a moment to fill out the evaluation that pops up on your screen. If you are interested in the certificate of attendance for today's presentation, these will be automatically emailed to you within 1 week of the presentation. If you do not hear from us by next Friday, then we have missed you. So please give us until end of day next Thursday to get that certificate, and we will get that out to you if you've joined us for 45 minutes or longer. If you have missed previous online Grand Rounds, you can find that through following the directions on your screen, and we're also always happy to send a calendar appointment for those of you who would like to get this on your calendar going forward. I want to invite you to join us next week. We're having 2 COVID-related Grand Rounds in a row here. Next week, both for Heart Month and because there's been so many questions about the cardiac implications of COVID-19, we will have Dr. Chris Carter, one of our pediatric cardiologists, joining us from the Children's Heart Clinic. He'll be talking a little bit about some of the implications of acute COVID-19 infections on the heart, MISC, as well as what we do about kids returning to sports and activities after they've been exposed to COVID-19. As always, join us on Fridays for our Talking Pediatrics clinical podcast. This Friday, we have another interview with Patsy Stinchfield, our COVID incident commander here at Children's Minnesota. This week on Talking Pediatrics, we'll be talking a little bit more about vaccination, how that's going, what we can expect, when we can expect kids to be vaccinated, what's happening with clinical trials for kids. So a little more information about that coming out tomorrow on Talking Pediatrics. Please save the date for Friday, May 14th for our virtual Mental Health for Primary Care Conference. We'll be talking about mental health concerns for the school-age years, and we will have registration information available soon for that. And now, it's my pleasure to introduce our speakers this morning. Joining us today are Dr. Gabby Hester and Dr. Anu Kalaskar. For those of you who don't know them, Dr. Hester is a hospitalist and the Medical Director of Clinical Outcomes at Children's Minnesota. With her role as Medical Director of Clinical Outcomes, Gabby focuses on evidence-based clinical guidelines, factors for guideline adherence, and patient outcomes. Since COVID-19, she's also been dabbling in telehealth implementation, as well as a recurring guest host role on our Talking Pediatrics podcast. So many of you may have heard her in Guidelines with Gabby. Also joining us this morning is Dr. Anu Kalaskar. Dr. Kalaskar is the co-medical director of infectious disease here at Children's Minnesota and is currently serving as the medical specialist on our COVID-19 command center in response to the pandemic. Welcome, and thank you for coming back to join us again this morning.
Thank you so much, Angela. Thanks for having us back today. I wouldn't have thought that in 2021, a year after hearing about this virus, we would still be here, but here we are, although maybe, hopefully in a better place than, at least towards the end of the year. Dr. Hester and I are going to talk about MISC today as an update, and the title was tweaked a little bit from everything you need to know about MISC to not quite everything you need to know, because as we know, it's impossible to know everything about a subject, especially a new illness that we're still learning about. I wanted to say specifically that, MISC is by nature an illness that involves, all parts of the body, multiple organs, and therefore the management of patients with MISC is really a multidisciplinary, it's multidisciplinary care involving multiple specialists. And so I just want to, acknowledge that there are multiple providers who are involved in the care of these patients. Specifically, I wanted to say that I won't be talking much about pathophysiology or the proposed immunologic mechanisms of MISC, which obviously are a big part of it, but I wouldn't be able to do it justice as our immunology colleagues would. I am grateful, though, to Dr. Pozos, who is on the line and has made herself available for any questions related to immunology and MISC. So just to get started, so these are our objectives. I'll start with epidemiology and then review clinical presentations. I'll describe specific patient characteristics in Minnesota. And then I'd just like to emphasize the difficulty in distinguishing MIS-C from other illnesses. And then Gabby will be reviewing the guidelines. So in terms of epidemiology of MIS-C, this is one of the first articles, and actually 9 months ago in May was our first MIS-C presentation that I did with Dr. Pozos. And so this was a hot off the press article at that time. And if we kind of think back to when MIS-C started, the first cases were reported in Europe and Italy and then the UK. It's just a handful of cases. That was the first information that we had out. And then soon after that, if we remember back to that time period, that would have been March, April, May, New York became the epicenter of acute COVID in the United States. And then soon after that, cases of MIS-C were identified in the United States. And so this article goes into some epidemiologic and clinical detail on a couple of hundred cases of MIS-C, and was one of kind of the first articles to really show that temporal relationship between acute COVID and development of MIS-C. And so we can see on the right graph, the peak of MIS-C cases occurred anywhere from 3 to 6 weeks after the peak of acute COVID cases. And that's something that has, remained true even now into 2021. And so that's something that will be highlighted as well as, as we learn more and more about MIS-C, some things have really remained consistent. This is the most up-to-date information about cases in the United States as of Monday. And so, thinking back to the previous slide, there were a couple of hundred cases that started out in New York. Now we're up to over 2,000 cases. There have been a total of 30 MIS-C deaths who have met the case definition. And we can see that, really every state at this point is involved, except from perhaps some in the very top northeast there in Maine. But in general, most states are involved and with a very high number of cases. And then something that's very interesting is that 99% of cases have been positive for SARS-CoV-2, either by PCR or by antibody testing, and 1% have had an epidemiologic link to COVID. So they've been around someone with a known COVID. So there's always been a link to COVID in all of these cases. This graph represents the daily MIS-C cases as a 7-day moving average. And so we can see that first peak occurred in sort of early May. And then since then, we had another peak in the summer. And that peak really correlated after we had kind of started lifting, regulations, and after a big holiday, the July 4th holiday, when people were gathering together. And so it's not too surprising that there was an increase in cases, about a month after that. And then the next peak has started the end of November. Now, the data in the grayed out area is not quite finalized. So that's the most recent 6 weeks of data because the case reporting is incomplete. And so data is still being gathered in that time period. But we know that, at least anecdotally from our service at Children's, that we had a very high number of cases in that time period. This is a breakdown of cases, first by race and ethnicity on the left, and then gender on the right. And we can see there on the left that, as is the case with acute COVID or more severe cases of acute COVID with hospitalizations, Black and Hispanic kids are most likely to be affected. And so 69% of cases are in children who are Hispanic or Latino or Black. And that has also remained true, since the beginning of reporting and looking across multiple countries as well, which I'll show a little bit later. In terms of gender, there continues to be a male predominance, with 58% of cases being male. And then by age group, most cases occur in the ages of 1 to 14 years. The median age is 9 years. That is something that has also really remained steadfast. Cases have been reported in less than a year of age up to 20 years of age. So there's really a very broad, spectrum across all age groups in the pediatric population. But the patient that you're most likely to see with MIS-C is, an 8, 9-year-old that has previously been completely healthy. That's sort of the typical patient that we think of. In terms of Minnesota cases, this is looking by week of diagnosis. We've had a total of 66 cases. We've not had any deaths in Minnesota. And this graph correlates the MIS-C cases to kind of what was going on in the community with acute COVID, at interval before the peaks of MIS-C. And so we can see that first week in week 21, we had about 5,000 cases of acute COVID around May 17th, with a peak of MIS-C a few weeks after. Then things kind of died down, and then in August, there were about 5,100 cases per week of acute COVID, with a little bit of a spike after. And then we see, as we know, that the incidence of acute COVID really skyrocketed starting in, about September, October, November. And so by mid-November, there were about 44,000 cases of acute COVID per week, with a very significant jump in MIS-C cases thereafter. So in terms of incidence of MIS-C in Minnesota as a proportion of total cases, this graph on the left breaks down number of acute COVID cases by age group from 0 to 19 years of age. And the table on the right compares MIS-C cases to total number of cases of acute COVID versus hospitalized versus ICU, and then deaths. And we can see that really MIS-C is an extremely rare complication of a SARS-CoV-2 infection. So if we look at the number of cases in Minnesota, this data is a little bit older than the most current 66 cases we have. So this is using 62 cases, but 62 out of over 75,000 cases leads to about 0.8% case proportion of MIS-C. So it's really very, very rare. And the other thing to remember is that over 75,000 cases are test positive, and so the actual number of cases is much, much higher than that, bringing down the likelihood of MIS-C even lower. There's some new modeling that suggests that the number of acute COVID and the number of infectious COVID patients at any given point in time is anywhere from 4 to 10 times higher what the testing numbers are for that day. And I just wanted to thank Dr. Sarah Lim at MDH for providing these slides for me. This is a breakdown of the MIS-C cases by age group and by gender and by race, and we can see again that this really fits very similarly with national data, with the CDC data. And so in terms of median age, we're right on, 8 years nationally, 7.9 in Minnesota. Gender, also a male predominance, and then there's also predominance in Black and Hispanic populations. I wanted to direct everyone to an addition to the patient surveillance children's COVID-19 tracking. And this has been added starting the beginning of this year, looking at MIS-C cases that we've had at Children's. And so the middle graph there depicts cases by day. In the top, it's by week, and then the bottom right by month. And the information that is used to make these graphs is gathered from a patient list that is managed by the infectious disease and immunology groups. And so there are patients on the list that have not gone through the full process of, the full sort of vetting process of being a confirmed case of MIS-C. And so when we have a patient in the hospital who we think has MIS-C, we alert MDH, and so that specifically Dr. Sarah Lim. And, after a discussion and completion of a case report form and waiting for some more confirmatory things like labs and things like that, those case report forms are completed and then reported on to the CDC, who has their own confirmation process. And so that whole process can take, as you can imagine, up to a month at times. And so the information that is displayed here may not be, may not match 100% with the number of cases in the state that have been confirmed from children's, but is very, very close. And so we can see that towards the end of last year, we had a big spike in MIS-C cases. And then this is showing number of cases since the beginning of the year. And we can see that things have really died down over the last, month or so. In terms of the Minnesota cases, this matches also with national data that the vast majority have positive SARS-CoV-2 testing. So of 62 who had a PCR test, 58% PCR positive, and then 92% were antibody positive. So over half were both PCR and antibody positive. There were 3 patients who were negative by PCR and serology, but they had been exposed to a confirmed case and therefore met the definition using that criteria. And then this is a summary of all Minnesota cases, the hospital course and treatment of all Minnesota cases. At this point in time, the number of children's cases, the proportion of children's cases was 42. So we have had, the majority of cases here, children's over 70%, and there are, more cases that we've had since then that are being confirmed, so that number is likely higher. But patients were hospitalized for 3 to 52 days was the longest hospitalization. The mean was 9.2 days. 58% were admitted to the ICU. The mean length of stay in the ICU was 3.3 days. What's really striking is that 55% of patients had abnormal echo findings. This is extremely high, even when we think about sort of the, I don't want to say counterpart, but the other illness that really first comes to mind when we think of MIS-C is Kawasaki disease. Even with the natural course of Kawasaki disease, that is untreated Kawasaki disease, the rate of abnormal echo findings, or that is to say coronary artery aneurysm changes, is not this high at all. It's less than half this number. So this is something that is very striking, that 55% of patients had some type of echo change, and those included coronary artery aneurysms, left ventricular dysfunction, small pericardial effusion, and mild MR. All cases have been discharged from the hospital. Again, we've not had any deaths in Minnesota. In terms of treatment, 18% received IVIG alone. IVIG plus steroids was a majority of patients, 68%. And then there were 8 patients who received IVIG steroids plus other immune modulators. Only 1 patient received steroids alone. And so in terms of our children's cases, the infectious disease and immunology group are beginning a process to look at our cases in detail. Epidemiology, clinical findings, lab findings, there's cytokine panels. These will all be looked at in a research, setting. And so we'll have more information about our patients specifically. But when we look at this data, we know that this really represents a large, the children's cases make up a large representation in this patient pool. So, and then I'll move to clinical update. This is the case definition of MIS-C from CDC. This has really not changed, really from, honestly, the beginning. So an individual who's less than 21 years, who has fever, a fever is a cardinal feature, any laboratory evidence of inflammation, clinically severe illness, and then multi-system organ involvement with greater than or equal to 2 organ systems. There's no alternative plausible diagnosis. So if you have a microbiologic test that becomes positive and explains everything, then they would not fit the criteria. And then they have a positivity for current or recent SARS-CoV-2 infection or an epidemiologic link. This is from that paper that I displayed in the beginning that detailed mostly patients from New York. And as I'll show in the next slide, really little has changed in terms of what we know or what we've seen and how patients present with MIS-C. So, still GI involvement is one of the most likely organs to be involved with GI symptoms, abdominal pain, vomiting, and diarrhea. Mucocutaneous involvement is very high. Respiratory involvement is very high. And then neurologic and renal involvement are very much less likely to be seen. The kind of color schematic on the bottom shows the overlap in organ system involvement. And so the organ systems there are listed on each axis. And we can see that, GI and cardiac, hematologic, those are the ones to line up most and most likely to exhibit symptoms in those organ systems. And so this is hot off the press, just published in Pediatrics this month, and is the largest international surveillance of MIS-C patients. And so it includes patients from 33 participating hospitals in Europe, Asia, and America. And what is distinct, one of the distinct things I just wanted to highlight is that the clinical features continue to remain the same. So fever, again, is cardinal, but mucocutaneous symptoms and GI symptoms are, top of the list. And so those are always, MIS-C is always something that very needs to be strongly considered in a patient who presents with those symptoms. Conjunctivitis and lymphadenopathy, and then again, neurologic symptoms are much less likely. This is a color schematic that highlights the difference in presentation between kind of the 3 categories that patients in this study were broken up into. And so they looked at patients who were KD-like, incomplete KD-like, and then patients who presented with shock. And so, the symptoms that were exhibited in each of these categories are pinpointed here on this diagram, and then a line is drawn through those. And so we can see that for the KD-like patients, it's just like we expect with Kawasaki disease. They're more likely to have mucocutaneous involvement, conjunctivitis, lymphadenopathy. And then when you go to the shock patients, they're much more likely to have cardiovascular symptoms, respiratory symptoms, GI symptoms. So there is some overlap, but they are quite distinct. In shock patients, they have significantly lower platelet count. They have a higher BNP, D-dimer, CRP, and ferritin. These are all significant. Again, they demonstrated, just as in our Minnesota data, that the echo at admission is very much likely to be abnormal. So 66% of patients had abnormal echo with dilated coronaries for the KD-like illness, and in shock patients, the predominant feature was left ventricular dysfunction. One thing that's great about this paper is that they were able to follow patients, throughout the course, but then after discharge as well. And what they found was that the shorter the duration of symptoms before admission, the more likely the patient was to have a worse outcome, needing inotropes, needing mechanical ventilation, basically needing critical care. And there was an increase of 72.3% risk of worse outcome per everyday reduction, which makes sense when we think about shock patients who decompensate very quickly and present quickly. And so finally, I just wanted to emphasize the difficulty in making the diagnosis of MIS-C. So as we looked at the case definition, we know that the definition is very broad. So fever, elevated inflammatory markers, multi-organ system involvement. Well, there are so many things that can look that way. And it can be very difficult to distinguish between the two. And so as Gabby will go through, we have specific guidelines to help with that process. But each case really needs special attention to determine whether it truly may be an MIS-C case. And so in this study, which is a very small study, there were only 39 patients. They included patients who had an echo or a room consult. That is what triggers that is the first step in their MIS-C protocol. This is a paper out of Boston. They identified 19 with MIS-C using the Massachusetts Department of Public Health definition, which is a little bit more permissive because you only have to have one organ system involved. So they may have picked up, even more patients than we would if we use the CDC definition. But they identified 11 non-SARS-CoV-2 infections. 3 of those had a non-SARS-CoV-2 infection plus MIS-C. 8 were bacterial, 3 were viral. They didn't go into too much detail of what types of infections, but we do know that at least a couple of the patients had a staph toxic shock syndrome. And some of the conclusions that they saw, granted it's a very small number of patients, but there was no significant difference between the patients with MIS-C and with non-SARS-CoV-2 infection when they looked at clinical features, vital signs, days of fever, lab abnormalities, with the exception of ferritin, illness severity, and then non-cardiac outcomes. So the main significant difference that they saw was that MIS-C patients have a much higher ferritin level than patients with a non-SARS-CoV-2 infection. And so the median there is 538 versus 111. So this is something that, we do kind of pay special attention to. No significant difference in CRP or procalcitonin. And the main gist of the paper is just to avoid premature diagnostic closure. And so as Gabby talks about, the guideline and looks at a paper that looks at the use of steroids in the treatment of MIS-C, which we know is very important, we just want to make sure that we're not arriving at the diagnosis of MIS-C too soon and that we're considering all other possibilities, especially other possibilities that might be strongly affected by the use of steroids. And so just for an example, quickly at Children's, patients that have been, thought to have MIS-C have had other diagnoses, including multiple cases of pyelo, nephrotic syndrome, of course, Kawasaki disease, perforated appendicitis, vaping-related injury, salmonella, and really the list goes on. And so that is just always something to keep in mind about MIS-C, is that it's a very, can be a very difficult diagnosis to make. And so I will turn over now to Dr. Hester.
Good morning, everyone. So I think the most important slide that I'm going to present today is just this first one. So how do you find these guidelines? And everything that we know about MIS-C and everything COVID-related really is evolving and changing. And so our guidelines also need to evolve and change to keep up with that. So our guidelines can be found internally on the StarNet. There's a clinical guidelines tab in your left column, but you can also access them externally. These are available to the public. So at childrensmn.org, if you go to Health Professionals tab, then there's a clinical guidelines link that will get you to this guideline. So when we pulled together our guideline, this is a really evolving topic, and Dr. Kalaskar appropriately pointed out that this is really a multidisciplinary team. We need all hands on deck, really looking at this patient from different lenses of expertise. So similarly for our guideline, we pulled together people from all different areas of the healthcare continuum, and we have representation listed here, including representation from physicians and then building up our nurse representation as well, recognizing how valuable they are in caring for these patients. In addition, we also work with our COVID clinical core, the HICS, the Hospital Incident Command Center, and then our Guideline Governance Council to really make sure our guideline is appropriately developed and in our branded template that we use. In building the guideline, initially we really had to rely a lot on that expert opinion, and of course we always want to be as evidence-based as possible, but with a new disease, the evidence really wasn't there in the beginning. So building together expert opinion, both from our local experts as well as evolving experts around the world. And so I know Dr. Kalaskar and myself and Dr. Kutsari and Dr. Pozos and many people have spent hours and hours listening to really wonderful webinars and conversations from people who are on the front lines in different parts of the world, really trying to understand this condition. thankfully there has been the development of some additional resources like national guidelines. So the American College of Rheumatology guideline has been really helpful in developing a process to care for these patients. We also look at the AAP interim guidance, some helpful information from the CDC, of course, and then other hospitals around the U.S. that have experience with MISC, and I'll point out the New York Presbyterian Children's Hospital that really was at the forefront of the COVID surge back in the spring and was seeing a lot of these cases early on. We do know that this is an evolving disease with a spectrum of illness, and I think early on we really were hearing about and focused on those critically ill patients. Over the last few months, I think we've broadened our understanding of the breadth of the illness spectrum and are really understanding a little bit more about that milder aspect of illness as well. So first we were seeing the tip of the iceberg, and now a little bit more of that iceberg is becoming uncovered. So because of that, we do have dedicated pages for the guideline for each care location, recognizing that different children are going to access the healthcare system in different ways. I will not walk you through every detail of the 8 pages of the guideline, but I do want to take a moment, on this page just to point out sort of the format that our clinical guidelines take. If you haven't seen one of our guidelines before, this just orients you a little bit to see that on all of our guidelines that there's a banner at the top, and that should help you identify what your audience is. So in the upper left, you can see this is a clinic guideline for this particular page. We see in the middle then the disease process, where this is for suspected MISC. So we know that a lot of kids are going to be sort of evaluated using this guideline. Many of those children, most of those children actually will not ultimately have the diagnosis of MISC. For that reason, it's really important to think about what patients are excluded from your guideline. So there's this red box in the upper right corner that goes through some of the alternate diagnoses for a patient who may look similar to MISC on presentation. And as Dr. Klaskar pointed out, it's extremely important not to forget about all those really other important causes of disease that would require different management for patient care. On this clinic guideline, we really are trying to keep it simple. We know that folks in the clinic setting are extremely busy seeing lots of patients. And so we distinguish it into stable patients and unstable patients. For unstable patients, really, as would be the case with really any disease, we would ask them to transfer that patient to the emergency department after initial stabilization. But if the child is stable, we can consider obtaining what we call the Tier 1 labs. And so those are some fairly routine types of labs that you could, in most clinic settings, obtain that will help you understand if what you're seeing is more likely to be MISC, or if another diagnosis should be more strongly considered. With that, of course, thinking about your other reasons for presentation and obtaining those tests as you would even in the era prior to MISC. So if the child has a fever, abdominal pain, and a sore throat, certainly thinking about doing a strep swab before you would obtain those Tier 1 labs would be very reasonable. While we know that there are no absolute gold standards for how you discriminate between MISC and other illnesses at this time, we are starting to learn a little bit more about some factors that may point you in one direction or another. So this study looked at 44 patients who ultimately carried a diagnosis of MISC and compared them with 181 children who were evaluated for febrile illness. All of those patients were seen in outpatient clinics. And at that time, they were able to determine that children with MISC had a little bit higher fever, more prominence of abdominal pain, neck pain, those mucocutaneous findings, CRP, and a lower absolute lymphocyte count and platelet count. Now, if you have any one of those features in and of itself, that certainly doesn't mean that it is MISC, but just some things that you would want to think about as far as being a little bit more likely to be MISC than perhaps another illness. Once we get into the emergency department, we do know that children, of course, will still access care in the emergency department, perhaps even if they're a little bit more well-appearing, just depending on how that family uses the healthcare system. So in the ED, in the ED, we also have the option of going down a very similar path to the outpatient clinic with your Tier 1 labs. But of course, if the child is more ill-appearing, we would recommend a more aggressive workup from the beginning, thinking about the Tier 1 and Tier 2 labs, and I'll talk a little bit more in detail about those in a moment. These pages also try to give you suggestions of what labs would indicate an abnormality. And so there's a box here in the center, in the lower center here, talking about some of those lab thresholds that you would want to be thinking about. So how are we doing compared to other children's hospitals? So this study looked at, it was a survey of 40 U.S. children's hospitals and just asked them, what are you doing for your MISC management? And most of them had a similar tiered approach to the workup, using these Tier 1, Tier 2, and Tier 3 type of labs. And part of the concern with MISC is that we're seeing a lot of kids coming in with fever, abdominal pain, and rash. And pre-MISC, those kids may have been treated with supportive care and really just sort of watchful observation. Now they're getting a ton of labs done, and certainly that means discomfort with the lab draw for the child or the family, and then a lot of healthcare use, a lot of resource utilization and cost for the healthcare system. So it's sort of a balancing act right now. We don't want to miss kids with MISC or their other potential causes for diagnosis. At the same time, we want to be judicious about the labs and tests that we're doing. So that's where we have the tiered approach of really trying to understand a stepwise, thoughtful process to how we can evaluate these children. And I'll say that we have this large multidisciplinary team of stakeholders on our MISC guideline group, and we're continuously evaluating to determine if this is still the right approach. We actually just met yesterday and talked again about our labs in the different tiers to say, is there any way we can pare these down at this time? Once you've been admitted to the hospital, we have a couple of different pages that talk through the management depending on the level of severity of illness. So this page is showing you the ICU management that we recommend. And really, it's a lots of words, very detailed page, and that's really to try to get in one place all the recommendations for that healthcare team so they can initiate the treatment as quickly as possible when it's felt to be when MISC is felt to be the diagnosis. So all these patients will have an echocardiogram. All of these children will be on telemetry after admission as well, because we know they can develop cardiac arrhythmias after presentation. In children who are critically ill in the ICU, they'll all be on empiric antibiotics because, of course, as we've mentioned, we can't effectively exclude other causes of illness right in the beginning. So we do want to be watching those cultures and treating them empirically in case they have a bacterial source of illness, for example. Multidisciplinary collaboration with our specialists, and then all patients will get Ivig, and in the critically ill patients, with few exceptions, would get steroids as well. All patients with MISC will be treated with low-dose aspirin. This is for the antiplatelet effect as well as some coronary artery protection. And with that low-dose aspirin, they'll also be started on prophylactic Lovenox. Some patients will be actually on therapeutic Lovenox if they have certain criteria, such as a really low ejection fraction. And then in the patients who are receiving steroids, they'll be on GI prophylaxis. A lot of labs are trended in these patients, and so there's recommendations on the guidelines for how frequently to obtain those labs, EKGs, and repeat echocardiograms. The next page is very similar, the med-surg guideline. There are a few distinctions, more tailored approach to antibiotics, more consideration as to indication for steroids. So not all patients in this category would be necessarily treated with steroids, and we really want the teams to be taking a collaborative approach and working with ID and immunology in most cases to determine the appropriateness of steroids for that particular patient. And then on this page, we also talk about discharge criteria. These children will be at some point getting ready to go home, and so we have some recommendations of the things that we'd like them to be doing before they would be ready for that step. We also recommend when children are preparing to discharge to home that we consult with endocrinology for patients who are going to be on steroids for 3 weeks or longer. And that is because they will be at risk for developing adrenal insufficiency from the steroids that we're giving them. And so that's part of the plan, is planning for their endocrinology follow-up. So just as a quick summary, what we recommend in our guideline for treatment is for all patients, unless there's a rare exception, would receive Ivig, aspirin, and VTE prophylaxis. Many cases, as we've seen in our study, Dr. Klaskar mentioned that 68% of patients at our hospital also receive steroids. And then supporting for these treatments would be GI prophylaxis, empiric antibiotics, and then calcium and vitamin D supplementation if they'll be on prolonged steroids. This is similar to the approach other children's hospitals are taking. So I mentioned that study by Dove et al., the survey of 40 different children's hospitals, and they also are taking sort of a tiered approach to steroids, and you can see that in mild cases they're using, this is around the country, 20% of them are receiving steroids, and then up to the severe cases, 85% of children are receiving steroids. Similarly, in the American College of Rheumatology guideline, this was updated in November of 2020, their first-line treatment for the severe illness, kids who have shock or organ-threatening disease, would be IVIG plus steroids. If they're not that severe, though, they are recommending at this time just first-line treatment with IVIG alone. So I do want to speak briefly about a new study that came out just a few weeks ago because we continue to learn more about the appropriate treatment. And so this study was a retrospective study of 111 cases of MISC in France. And they looked at IVIG plus methylprednisolone versus IVIG alone. And they used a statistical tool called Propensity Scoring. And if you're not familiar with that, that's a way to have essentially an observational study which normally wouldn't, you would worry that maybe your baseline characteristics weren't the same in each group. So for a randomized control trial, you can control so that you're controlling and matching apples to apples. With observational studies, you need to use a statistical method such as propensity scoring to then be able to compare like individuals. So this is something that's applied after the study so that you can use the outcome of this in a similar way to a randomized controlled trial. Their primary outcome was treatment failure, which they defined as ongoing fever 48 hours after their initial therapy. And they had some secondary outcomes, although I'll say that the study was not powered to look at those outcomes, and they also didn't control for multiple comparisons. So for results, they did show that kids who had IVIG and steroids had a lower rate of treatment failure, and that was significant. So 9% in kids who had IVIG and steroids versus 38% in the IVIG alone. For their secondary outcomes, they also favored IVIG and steroids, so as I noted, we have to be cautious of our interpretation of those results. So many limitations, potential for unmeasured covariates, but I think the big one is really what we've talked about already many times. What if it's not MISC? So this study was looking at kids who, we are looking back in time and know that they had MISC as their ultimate diagnosis, but when you're treating the child, you're standing looking forward. So you have to make sure that it is MISC and not something else where steroids may worsen your infectious process. I'm going to kind of skip through a couple of the next slides because I want to leave time for questions, but we do have some pages for MISC kids who don't yet meet the criteria for MISC. So these are kids who are kind of admitted for a rule-out MISC. How do we train those labs? What are we looking for, and what are the things we want to see before we would discharge them to home? And I'll note that there are many children. I saw there was a question from someone in the audience about sort of that spectrum of illness, and we are starting to see more mild cases, even mild cases that will meet the definition for MISC and would need admission to the hospital for their treatment, which is IVIG, and that close monitoring, but they may not meet other admission criteria that we typically think of, like needing respiratory support or cardiovascular support, for example. We have a whole page dedicated in our guidelines to post-hospital care. So if you're listening from an outpatient clinic right now, I really encourage you to go to that childrensmn.org website and really check this page out because I think this will be really helpful for you in taking care of that child after they're discharged. There's a lot of follow-up that will happen for these children with their PCP, with cardiology, with endocrinology in many cases, and then also watching for things that would require readmission. So those complications to watch for would include watching for return of MISC symptoms, any cardiac complications, and then iatrogenic complications from things we've actually done to them. So we know that IVIG can have some side effects, as well as the steroids that we're prescribing for these children. I also put on here mental health changes. We know with everything related to COVID and just the era that we're in right now, it seems there's a lot of behavioral health and mental health concerns that are happening in our children. And we know that severe illness is also a risk factor for developing mental health concerns. There was actually an interesting study a few years ago about patients with Kawasaki disease, looking at their quality of life using a validated tool and comparing them with children with cancer. And actually they found that children with Kawasaki disease had parent-reported lower quality of life scores than children with cancer. So very surprising study to me, and we certainly haven't done one yet in patients with MIS-C, but I think it's an important thing to think about. I am going to kind of skip through the outcomes of MIS-C because I would, like I said, want to save time for questions, but thankfully children have been doing well after diagnosis. And like Dr. Klaskar said, we have not seen any deaths in our population of MIS-C patients here at Minnesota. And that's what these studies I'm showing also show, is that most children are returning to normal cardiac function at some point within their follow-up. We have an additional page of sort of tips and additional notes. And I'll just end with sort of the key points of the guideline are really, remembering your ABCs, stabilizing that patient, and keeping your differential diagnosis broad. We're worried about premature closure for the diagnosis right now, and so it's really important to remember sepsis, remember other causes of illness that would require different management. Working as a collaborative team, thinking about your tiered labs and imaging, and then the treatments that I walked through and the follow-up, as I mentioned, with PCP, cardiology, and in many cases, endocrinology. We are right now finalizing some patient family education materials. So we've been partnering with folks at CPDP and really reaching out to our family advisory councils to get input on this in really having good education for families, because certainly if you Google MIS-C, there can be a lot of overwhelming information they might find. So we want to make sure we have developed some materials that they can refer to. I'll point out two additional resources. One is the COVID Clinician Toolkit that's available on StarNet. And then our podcast, Talking Pediatrics, looking at Dr. Gepford over there, who's the host of Talking Pediatrics. And we've had several episodes talking about MIS-C, including one 2 weeks ago where Dr. Gepford and I had a nice conversation about MIS-C. So definitely check that out wherever you get your podcasts. So I think at this time we can open it up for questions.
Great, thank you. I just want to revisit, first of all, you mentioned it, Gabby, in your comments, but there were two questions about possible minor MIS-C or sort of kids who may be out in the community that have mild symptoms and don't get diagnosed. And I just want to clarify that if there are kids who have more mild symptoms, that would they need treatment? Should they still be evaluated? What should be happening with those kids?
Well, I'm on the camera, so I'll take that. But I'm also going to look over at Dr. Klaskar and make sure that I'm not answering this incorrectly. My thought process would be that they should come into the hospital and have that really multidisciplinary evaluation for a couple of reasons. One, to make sure that we feel that that is the true diagnosis, because that would have implications for their follow-up and potentially for their outcomes as well. Many mild cases, we would also potentially recommend some treatment with IVIG in some cases, but I think having that team to be able to discuss in the hospital setting would probably be appropriate.
Mm-hmm.
Okay.
Yeah, no, I think that's great, Dr. Hester. I would just add,
we're just going to do this on the fly here, sorry.
I would just add that, as we learn more about acute COVID and MIS-C, there's probably a kind of a spectrum of illness, and the most severe cases that we see of MIS-C are likely kind of like tip of the iceberg. And so I can say, anecdotally, in an infectious disease clinic, we have been seeing a lot more cases of recurrent fever, persistent fever, whether or not that's related to COVID, we don't know. Maybe like some low-lying inflammatory process that's related to COVID is possible. So it is likely a spectrum of illness, and kind of delineating, when patients are severe enough or when the inflammation is high enough, or, what changes are there that require treatment is tricky. But I would say the main thing in those patients is that they should have very close monitoring, and lab monitoring as well. as Dr. Hester pointed out, the labs that should be followed as an outpatient would be the place to start. So.
And then while you're on the screen there, Dr. Klesker, there was a question. The international study that you showed about MISC, less than 70% were PCR or antibody positive. Was this because the tests were negative, or were they just not tested?
Yeah, I think it's because a lot of them were not tested. The definition that they used was the UK definition, so that's the PIMS-TS, which is short for Pediatric Inflammatory Multisystem Syndrome, temporally related to SARS-CoV-2. So that was kind of the first acronym or first definition as it was described in the UK first. But so their case definition does not require a positive SARS-CoV-2 PCR or antibody. And so, I think probably the reason that that number was a little bit lower is because of the UK patients that were included.
There's a question about any information about MISC in relation to the new variants that we're seeing, if it's more or less common with some of the newer variants that we presume are not more virulent but are more contagious. Any data?
I think that we don't know that yet. The way to determine if there's a variant involved is to do whole genome sequencing on a PCR. And when we think about MISC patients, they may have had a positive PCR a month ago that we don't have access to anymore. Sure. If it was done as an outpatient, or it's just we don't have the swab anymore to be able to do whole genome sequencing. But MDH has made a request that we send any, interesting, challenging, just cases where we think, oh, could this be somehow related to a variant, to them for a whole genome sequencing.
And I suppose by extension, as the variants potentially become more of a percentage of those who are infected, if we see then a rise in MISC cases, we can potentially make a correlation, but we may be a little out from that yet.
Yeah, it's hard to know.
There was a question about vitamin D deficiency. There's increasing evidence that vitamin D deficiency increases risk for more severe COVID disease. Of the few MISC cases I've seen, all have been vitamin D deficiency and severe vitamin D deficiency. Is anyone looking at whether vitamin D deficiency is also a risk factor for MISC, and are vitamin D levels being screened when kids are admitted or being evaluated, and should it be part of the treatment?
That's a great question. Yeah, I haven't personally seen any data on that or any studies on that, but that's, here in Minnesota, we really know about our vitamin D deficiency. So.
That sounds like a study waiting to happen.
Yeah.
Yeah, I'll just add to that there really is opportunity to add to the literature, I think, on the endocrinology outcomes associated with MISC. And so I see that this question is from one of our excellent endocrinologists, and I think that'd be a really cool thing to consider is some of the research opportunities, because as Dr. Klaskar said, I'm not familiar with any existing literature about the association of vitamin D deficiency and MISC, whether it's related to severity or treatment or outcomes, but I think it's a great question.
There was a question about, I believe we've heard of children dying from COVID recently, one in northwest rural Minnesota. Are these MISC cases, or do we know more about why these children died?
Yeah, I don't, I guess it maybe depends on the timing too, the process of reporting MISC cases, kind of going through that process can take some time. So it's possible that they just haven't, that child has not been, that the report has not been made, and there's still, that determination is still being made. But as of, at least the end of January, the last that I heard, there had not been any cases related to MISC.
Great. I don't see any other questions coming in, though there was a question very early on before we got started from one of our school nurses, and this question's on my mind as I just sent my children back to in-person school yesterday and went to pick them up as they were standing outside in below zero temperature on the basketball court waiting for me to get them. But the question was about differentiating COVID toes or some of the skin manifestations of COVID from frostbite. We discussed it before the presentation, and I actually did some research on it while the presentation was happening, and the advice I can give to that school nurse is there really is no way to tell the difference between frostbite and COVID toes. The presentation is very, very similar. You can biopsy it to know the difference, but in looking at the toes, it's very hard to tell. So I would say, given the COVID rates now, if you see a kid who looks like they have frostbitten toes, unless there is a very, very clear story that correlates it, I would get that child tested for COVID, and hopefully it's not, but either way, they need some kind of medical attention, whether they have frostbite on their toes or they need a COVID evaluation. So I think any child who looks like they have frostbitten toes should be referred for further evaluation, whether it's of the frostbite or getting a COVID test. So that is my answer to that question. And then I guess there was one last minute question that came in. We've got 2 minutes left. Do we know if Ivig and aspirin are actually effective for MISC?
So I think that this is kind of something that's addressed by the study that Dr. Hester went into with Ivig versus Ivig plus steroids. So we have had patients who have received only Ivig and have, recovered, but it does seem like the combination of Ivig and steroids is what's, really the treatment of choice to prevent any recurring symptoms or persistent symptoms of MISC. I think given the numbers of patients that we have with MISC and the time course, we're still learning a lot about how efficacious our treatment is. And so it is, the way our management has kind of evolved over this time period is something that may continue to happen.
Great. Thank you. I think we will close there. Thank you both again for joining us this morning. A reminder to check out our podcast for more information, and then also a reminder to join us next Thursday for Dr. Chris Carter from Cardiology talking about the cardiology implications of COVID infection. So we'll see you all next Thursday morning.